Welcome to Pediatric Case Review. Today we present a comprehensive overview of glycogen storage diseases, targeted specifically for clinicians and specialists. This lecture will cover classification, clinical manifestations, diagnostic approaches, management strategies, and the latest advances in treatment. Our goal is to enhance your clinical decision-making when encountering patients with these complex metabolic disorders. We will explore 12 case-based questions to test and reinforce your knowledge throughout this presentation. A 6-month-old presents with hepatomegaly, hypoglycemia, lactic acidosis, and growth failure. Which type of GSD is most likely? Option A, GSD type 2, Pompe disease. Option B, GSD type 1, von Gierke disease. Option C, GSD type 5, McArdle disease. Option D, GSD type 3, Corey disease. Consider the classic presentation features, including the combination of hepatomegaly with hypoglycemia and lactic acidosis, which are hallmark findings in one specific type of glycogen storage disease. The correct answer is B, GSD type 1, von Gierke disease. This classic presentation with hepatomegaly and hypoglycemia is characteristic of glucose 6-phosphatase deficiency, which prevents conversion of glucose 6-phosphate to glucose. Typical laboratory findings include lactic acidosis, hyperuricemia, and hypertriglyceridemia. Pompe disease typically presents with muscle weakness and cardiomyopathy, not primarily hepatomegaly. McArdle disease manifests with exercise intolerance and muscle cramps. Corey disease has similar features but typically milder hypoglycemia and progressive myopathy. A 3-year-old presents with muscle weakness, cardiomegaly, and respiratory issues. Which test is most specific for confirming GSD type 2? Option A, liver biopsy. Option B, acid alpha-glucosidase enzyme assay. Option C, fasting glucose test. Option D, exercise stress test. Consider the clinical presentation featuring cardiac involvement and muscle weakness, which are characteristic of Pompe disease, and think about the most specific diagnostic test for this lysosomal storage disorder. The correct answer is B, acid alpha-glucosidase enzyme assay. This test measures the activity of the lysosomal enzyme deficient in Pompe disease. It can be performed on dried blood spot, fibroblasts, or muscle tissue. Gene sequencing of the GAA gene provides confirmatory diagnosis. Liver biopsy is not specific for Pompe disease. Fasting glucose test may be normal in Pompe disease. Exercise stress test is more relevant for McArdle disease. The enzyme assay remains the gold standard for diagnosing Pompe disease, especially important given the availability of enzyme replacement therapy. Pompe disease diagnosis follows a systematic approach starting with clinical suspicion based on symptoms like muscle weakness, cardiomegaly, and respiratory issues. The diagnostic pathway includes dried blood spot testing as initial screening, followed by enzyme analysis to measure acid alpha-glucosidase activity. Genetic testing through GAA gene sequencing provides definitive diagnosis. Muscle biopsy may show vacuolar myopathy with glycogen accumulation, while cardiac involvement, particularly hypertrophic cardiomyopathy, serves as a key diagnostic clue in the infantile form. Different diagnostic approaches are used for infantile versus late-onset forms. A 4-year-old with GSD type 1 experiences an episode of hypoglycemia. Which intervention is most appropriate? Option A, immediate administration of glucagon. Option B, oral protein supplementation. Option C, oral glucose or dextrose administration. Option D, intravenous fructose solution. Consider the underlying pathophysiology of GSD type 1 and how it affects the body's ability to respond to different interventions during hypoglycemic episodes. Think about which approach would be most effective for rapidly correcting low blood sugar in this specific metabolic disorder. The correct answer is C, oral glucose or dextrose administration. Glucagon is ineffective due to depleted glycogen stores or inability to mobilize glucose in GSD type 1. Rapid glucose or dextrose administration is essential during hypoglycemic episodes. The oral route is preferred if the patient is alert, while intravenous dextrose should be used if unconscious or unable to swallow. Protein supplementation alone is too slow for acute correction. Fructose is contraindicated in GSD type 1 as it cannot be metabolized properly. Continuous glucose monitoring may help prevent severe hypoglycemic events, and regular cornstarch administration provides slow-release glucose to maintain normoglycemia. An 8-year-old with GSD type 1A is being managed for long-term complications. Which intervention is not appropriate? Option A, uncooked cornstarch therapy. Option B, continuous nocturnal gastric drip feeding. Option C, low-carbohydrate, high-protein diet. Option D, angiotensin-converting enzyme inhibitors for microalbuminuria. Consider the nutritional management principles for GSD type 1 and how different dietary approaches affect glucose homeostasis in these patients. Think about which intervention would be contraindicated or potentially harmful in this metabolic disorder. The correct answer is C, low carbohydrate, high protein diet. GSD type 1 patients require frequent high carbohydrate feedings to maintain normal glycemia. Uncooked cornstarch provides slow release glucose and is a cornerstone of management. Continuous nocturnal gastric drip feeding prevents overnight hypoglycemia. Angiotensin converting enzyme inhibitors are appropriate for managing microalbuminuria, a common complication. A low-carbohydrate diet would be harmful as it would worsen hypoglycemia in patients who cannot effectively mobilize glucose from glycogen stores. Protein intake should be adequate but not excessive. Dietary management aims to maintain normal glycemia and prevent metabolic derangements. Nutritional management varies significantly across different types of glycogen storage diseases. GSD type 1 requires frequent high-carbohydrate feedings with cornstarch therapy and restriction of fructose and galactose. Monitoring includes glucose, lactate, and lipid levels. GSD type 3 benefits from a high-protein diet with moderate carbohydrate restriction, monitoring CK, liver enzymes, and glucose. GSD type 5 management involves a high-protein diet with pre-exercise glucose, monitoring exercise tolerance and CK levels. GSD type 9 also uses a high-protein approach with carbohydrate modification, focusing on growth and liver function monitoring. All nutritional plans must be individualized with regular monitoring by a multidisciplinary team. A 5-month-old with infantile-onset Pompe disease is started on enzyme replacement therapy. Which statement is correct? Option A. Treatment should be delayed until respiratory symptoms develop. Option B. Earlier treatment initiation correlates with better outcomes. Option C. Cross-reactive immunologic material status does not affect treatment response. Option D. Enzyme replacement therapy is contraindicated in patients with cardiomyopathy. Consider the principles of enzyme replacement therapy for Pompe disease and the importance of early intervention. Think about how factors like timing of treatment initiation and patient characteristics affect outcomes. The correct answer is B. Earlier treatment initiation correlates with better outcomes. L-glucosidase alpha, marketed as Myozyme or Lumizyme, is the approved enzyme replacement therapy for Pompe disease, administered as biweekly intravenous infusions. Treatment should not be delayed until respiratory symptoms develop. Early intervention is critical. Cross-reactive immunologic material status significantly affects treatment response, with CRIM negative patients having poorer outcomes and higher risk of antibody development. Immunomodulation may be necessary in these patients. Enzyme replacement therapy is not contraindicated in patients with cardiomyopathy. In fact, it's indicated and can improve cardiac function. The earlier treatment is initiated, particularly before irreversible organ damage occurs, the better the clinical outcomes. A 12-year-old with GSD type 3 presents with increasing muscle weakness and elevated creatine kinase. Which additional finding would you expect? Option A. Severe hypoglycemia similar to GSD type 1. Option B. Mild, well-compensated hypoglycemia. Option C. Progressive dilated cardiomyopathy. Option D. Fixed muscular dystrophy without progression. Consider the clinical features and natural history of GSD type 3, also known as Corey disease or Forbes disease. Think about how this debrancher enzyme deficiency affects both liver and muscle tissue and what complications typically develop over time. The correct answer is C. Progressive dilated cardiomyopathy, GSD type 3, caused by debrancher enzyme deficiency in the AGL gene, affects both liver and muscle tissue. Cardiac involvement is common and typically progressive over time. Hypoglycemia in GSD type 3 is typically less severe than in GSD type 1 due to the ability to release some glucose from limit dextrin. The skeletal myopathy is progressive and can lead to significant disability. Severe hypoglycemia is more characteristic of GSD type 1. While mild hypoglycemia can occur in GSD type 3, it's not the most significant finding in a patient presenting with muscle weakness and elevated CK. The muscular dystrophy in GSD type 3 is progressive, not fixed, requiring ongoing monitoring and management. Which laboratory finding is not typically associated with GSD type 1? Option A. Hypertriglyceridemia. Option B. Hyperuricemia. Option C. Lactic acidosis. Option D. Hyperammonemia. Consider the classic biochemical abnormalities seen in von Gierke disease and how the metabolic block in glucose 6-phosphatase deficiency leads to various laboratory derangements. Think about which finding is more characteristic of other metabolic disorders rather than GSD type 1. The correct answer is D, hyperammonemia. Classic laboratory findings in GSD type 1 include lactic acidosis due to impaired gluconeogenesis, hypertriglyceridemia from increased very low-density lipoprotein production, and hyperuricemia resulting from decreased renal excretion of uric acid. Hyperammonemia is not typically associated with GSD type 1 and is more characteristic of urea cycle disorders such as ornithine transcarbamylase deficiency or carbamoyl phosphate synthetase deficiency. Hyperlipidemia in GSD type 1 can be severe, increasing the risk of pancreatitis. Hyperuricemia may lead to gout and nephropathy. Lactic acidosis contributes to the chronic metabolic acidosis seen in these patients. Laboratory findings vary significantly across different types of glycogen storage diseases and provide important diagnostic clues. GSD type 1 typically shows hypoglycemia, lactic acidosis, hyperuricemia, and hypertriglyceridemia with normal CK and transaminases. GSD type 3 presents with mild hypoglycemia and ketosis, elevated AST and ALT, elevated CK, and may show myopathy and cardiomyopathy. GSD type 4 demonstrates variable hypoglycemia, elevated transaminases, and markers of cirrhosis and coagulopathy. GSD type 9 shows mild hypoglycemia and ketosis, mildly elevated transaminases, growth delay, and hepatomegaly. These patterns help clinicians differentiate between GSD types and guide appropriate management strategies. A 25-year-old with GSD type 1 has been well managed since childhood. Which long-term complications should be screened for? Option A, lung fibrosis. Option B, hepatocellular adenomas. Option C, coronary artery disease. Option D, neurodegenerative changes. Consider the long-term complications that develop in patients with GSD type 1 despite good metabolic control. Think about which complications are most prevalent and require regular surveillance in adult patients who have had this condition since childhood. The correct answer is B, hepatocellular adenomas. Hepatic adenomas occur in 75 to 80% of GSD type 1 patients by their 20s. There is a risk of malignant transformation necessitating regular surveillance. Other long-term complications include nephropathy and osteopenia. Routine liver ultrasound every 6 to 12 months and alpha-fetoprotein monitoring annually are recommended. Lung fibrosis, coronary artery disease, and neurodegenerative changes are not typical complications of GSD type 1. Despite good metabolic control since childhood, hepatic adenomas remain a significant concern that requires ongoing monitoring throughout adulthood. Early detection of these adenomas is crucial for timely intervention and prevention of malignant transformation. Comprehensive surveillance for GSD patients involves regular monitoring of multiple organ systems. Liver surveillance includes ultrasound every 6 to 12 months and alpha-fetoprotein testing annually to detect hepatic adenomas and potential hepatocellular carcinoma. Renal screening with microalbuminuria and creatinine testing should be performed annually for early detection of nephropathy. Metabolic monitoring with lipid profile and uric acid every 6 months helps assess metabolic control. Bone health assessment with DEXA scans every 2 to 3 years identifies osteopenia early. This systematic approach requires a multidisciplinary team including metabolic specialists, hepatologists, nephrologists, and endocrinologists to provide comprehensive care and prevent long-term complications. A 16-year-old athlete experiences muscle cramps and weakness during intense exercise with second wind phenomenon. What is the pathophysiology? Option A, defective glycogen synthase. Option B, defective muscle phosphorylase. Option C, defective brancher enzyme. Option D, defective lysosomal alpha-glucosidase. Consider the classic presentation of exercise intolerance with the characteristic second wind phenomenon. Think about which enzyme deficiency specifically affects muscle glycogen breakdown during exercise and leads to this unique clinical pattern. The correct answer is B, defective muscle phosphorylase. McArdle disease, or GSD type 5, is caused by mutations in the PYGM gene encoding muscle phosphorylase, following autosomal recessive inheritance. The classic presentation includes exercise intolerance with muscle cramps and weakness, along with the characteristic second wind phenomenon. This occurs when alternative energy pathways activate after about 7 to 10 minutes of activity, as fatty acids and blood glucose become available for muscle metabolism. A key diagnostic finding is that lactate fails to rise during exercise testing. Management includes moderate exercise training, pre-exercise carbohydrate consumption, and a high-protein diet. Defective glycogen synthase causes GSD type 0, defective brancher enzyme causes GSD type 4, and defective lysosomal alpha-glucosidase causes Pompe disease, GSD type 2. Which emerging therapy shows promise for GSD type 1? Option A, CRISPR-Cas9 gene editing. Option B, messenger RNA-based enzyme replacement. Option C, adeno-associated virus-mediated gene therapy. Option D, all of the above. Consider the cutting-edge therapeutic approaches being developed for glycogen storage diseases. Think about the various novel technologies that are being explored to address the underlying genetic defects in GSD type 1 and whether multiple approaches might be promising. The correct answer is D, all of the above. Multiple cutting-edge therapeutic approaches are being developed for GSD type 1. Gene therapy trials are underway for multiple GSD types. CRISPR-Cas9 technology is showing promise in preclinical models, offering potential for precise correction of underlying genetic defects. Messenger RNA-based therapies could provide functional enzymes transiently but repeatably, leveraging advances from COVID-19 vaccine development. Adeno-associated virus vectors are being developed for liver-directed gene therapy, with some approaches already in clinical trials. Each approach has unique advantages. CRISPR offers potential for permanent correction, mRNA therapy provides flexibility in dosing, and AAV gene therapy may offer long-term expression. The field is rapidly evolving, with these technologies representing the future of GSD treatment. The emerging therapies landscape for glycogen storage diseases shows promising developments across multiple technological platforms. Gene therapy approaches are currently in phase 1 and 2 trials for GSD types 1, 2, and 3. CRISPR gene editing has demonstrated preclinical success in animal models, offering potential for precise correction of underlying genetic defects. Messenger RNA therapy is in early development for GSD types 1 and 3. The clinical implementation timeline suggests phase 2 trials from 2023 to 2025, phase 3 trials from 2024 to 2025, 25 to 2027, and potential regulatory approval between 2027 and 2030. Key challenges include immune responses to vectors and long-term safety concerns, while regulatory pathways may benefit from orphan drug designation and potential for accelerated approval. Parents of a child with GSD type 1 request genetic counseling for future pregnancies. What information is correct? Option A, 25% recurrence risk with each pregnancy. Option B, 50% recurrence risk with each pregnancy. Option C, X-linked inheritance pattern. Option D, maternal inheritance through mitochondrial DNA. Consider the inheritance pattern of GSD type 1 and how it affects recurrence risk in future pregnancies. Think about the genetic principles that determine the likelihood of having another affected child and what this means for genetic counseling. The correct answer is A, 25% recurrence risk with each pregnancy. GSD type 1 follows autosomal recessive inheritance, meaning both parents are typically asymptomatic carriers. With each pregnancy, there is a 25% chance of having an affected child, a 50% chance of having a carrier child, and a 25% chance of having a child who is neither affected nor a carrier. Prenatal diagnosis is possible through molecular genetic testing. Cascade family screening is recommended to identify other at-risk relatives. 50% recurrence risk would apply to autosomal dominant inheritance, which is not the case for GSD type 1. GSD type 1 is not X-linked, as that pattern affects males predominantly. Maternal mitochondrial inheritance would show maternal transmission only, not affecting father's genetic contribution. A 7-year-old with GSD type 1 requires appendectomy. Which perioperative management is essential? Option A, prolonged preoperative fasting. Option B, continuous glucose monitoring and intravenous dextrose. Option C, prophylactic steroid administration. Option D, deliberate hypothermia to reduce metabolic demand. Consider the special metabolic needs of patients with GSD type 1 during surgical procedures. Think about how the inability to maintain glucose homeostasis affects perioperative management and which intervention would be most critical to prevent metabolic decompensation. The correct answer is B, continuous glucose monitoring and intravenous dextrose. Avoidance of fasting is critical in GSD type 1 patients undergoing surgery. Perioperative glucose infusion rates should be calculated based on weight, typically 8 to 10 milligrams per kilogram per minute. Frequent blood glucose monitoring is essential to maintain normal glycemia. Coordination between surgeon, anesthesiologist, and metabolic specialist is crucial for optimal outcomes. Prolonged preoperative fasting is contraindicated and dangerous in these patients. Prophylactic steroid administration is not routinely indicated for GSD type 1. Deliberate hypothermia to reduce metabolic demand is unnecessary and potentially harmful. The cornerstone of perioperative management is maintaining normal glycemia through continuous dextrose infusion and close monitoring throughout the surgical period and postoperative recovery. Thank you for joining Pediatric Case Review for this comprehensive overview of glycogen storage diseases. Remember that GSDs require multidisciplinary management with comprehensive care teams essential for optimal outcomes. Early diagnosis and intervention significantly improve prognosis across all GSD types. Individualized treatment plans must be tailored to each specific GSD type and patient needs. We encourage you to subscribe to our channel for more informative presentations, and please comment with any questions you may have about today's content. Stay tuned for future episodes covering rare metabolic disorders and advances in pediatric care.